All right, so we are live. Good afternoon. This is United Medical ACO. My name is Kemal Erkan. Today is August 27th, our weekly Friday event. As we promised, we have some weeks we have guests from the our community, and today our state auditor is our guest, and we will provide a couple updates. But before I start doing that, I'm going to ask our state auditor to introduce herself, and then we'll start right after that. Kathy, welcome to our event, and hopefully everything is going well with you. If you can please, everyone knows you obviously, so but we just want to make sure that for those who may not know you, if you can please do an intro, and then we'll start from there.
Sure. Thank you for having me. Thank you for caring about this topic. My name is Kathy McGinnis. I am your Delaware State Auditor. I am one of 6 statewide elected officials. My office is a little different than the rest. I am actually an independent agency responsible for auditing the rest of the agencies and state tax dollars, and as well as federal tax dollars and different types of engagements. So thank you for having me here. I'm happy to give a little bit of background because quite honestly, most people have no idea we have a state auditor and what we do.
Thank you.
So with that, yeah.
Absolutely. So what we do in these, since the pandemic started last year, we wanted to have this outlet for our patients and also for the people in Delaware and United States to have some place that they can rely on the resources and the information that's being provided to them. As you may know, we have about 115,000 patients at the primary care level with about 175 primary care providers and specialists in the network. And they're all in one shared domain, which is helpful, efficient for the patients, for the system itself. And it helps us with the triple aim goal and making everything more seamless and cost effective. So now, while we were going through this, we wanted to give the updates on COVID. First, it was with the number of cases. Later on, it turned into more like COVID vaccination process. And then once the vaccine started, we put some videos out there to educate the public on vaccine. Our providers got the vaccines first, and my staff, we were on the 1A group, in the 1A group. And then we understood that some patients didn't want to get vaccinated. So then we put some other events, other education sessions for them. So now we are at the point where we use this for different topics in healthcare. Now, if you allow me for a couple minutes, I just want to give this our standard updates on the COVID, and then we keep them very short since I have you on the show today, so on the session. So these are our daily vaccination rate. So we're about 891,000 daily to reach to the 75% from Biden administration. We are about 4 months away from that. So we are hoping that we'll get to that level. If for Delaware, we are doing slightly better, but not, it's very similar to the national averages. We are hoping that we can improve this. You know, I'm not a clinician, but I actually do talk to the patients, and I do a lot of work on the patient charts for checking the standard protocols for our patients. And I had to talk to some patients, and there are some conversations that we have with patients with these vaccinations, and pretty amazing stories. And I had one from last night, and I was on the phone for almost 40 minutes patient with some chronic illnesses and doesn't want to get vaccinated. And it was so interesting what they come up with. And how do you actually really beat that? It's almost impossible. So, but we want to help them. So that's kind of the challenge. Now, in the meantime, FDA approves the first COVID vaccine, COVID-19 vaccine as the fully approved. Of course, they were all approved, but that was on the emergency basis. So Pfizer is the first one fully approved at this point. Now, before we start our discussion, we brought a lot of different state officials here, and I'm not going to be shy about my own interest in politics. My major in school, I was double major, and one of them was political science. You guys are policymakers in some cases, and we have to know what these are, and then we have to know how these policies are being made and who's actually overseeing them. And your situation, your position is kind of different than others. So it's an independent position, if I understand that correctly, right? Now, but even for me, I don't know enough what you do, what your position does. Just for the simple terms, simple words, what do you do?
Okay, so my office, which is an independent agency, basically wants to make sure that Delawareans are getting a fair deal with their money. We have oversight of the state agencies and the monies. So what you just spoke about earlier, we have in the past inspired legislation in the General Assembly. There's a lot that I would like to hopefully work together with other entities and collaborate and hopefully do some things in the future. For example, maybe in the PBM or other areas, which will help with government waste. We look to root out fraud, waste, and abuse. We have a very active hotline, and now we have a fraud app that we developed for your phone. And I will tell you, we had over 1,000 contacts or communications letting us know about fraud, waste, and abuse in the past fiscal year, which was about more than the previous 10 years combined. So it's very active. It's fraud.delaware.gov. We do several types of engagements. We don't just do financial audits, performance audits. We do examinations, inspections, agreed upon procedures. Now, according to Title 29, Chapter 29 in the code, there's certain things that we are supposed to be doing. And then some things, a lot of things actually are sparked from our fraud hotline. You may not know it because it may not be an investigation. It could end up being a performance audit or a special report, but a lot comes from the fraud hotline. We also have implemented a risk assessment survey statewide. So we let the state employees come to us anonymously and tell us, and we have all those analytics. So what we're doing now is we are your fiscal watchdog. That's what they've called us. I didn't make up the name. I inherited it. And we want to make sure that what we are doing is holding other folks accountable. And so we're fighting for accountability and transparency across the board. Something I would like to say is, when I was elected to this office, my predecessor had been in for 30 years. So whoever took over this office was going to have a different direction. And what I wanted to do was put Delaware on the map. And I just spoke in San Diego last week at the National Association of State Auditors, Comptrollers, and Treasurers. And I can tell you, Delaware's on the map. When you have someone like Elaine Howe, the state auditor of California, say, we're watching what you're doing, we're following you, keep up the good work. Delaware's on the map. So what we want to do is we do different types of engagements. And this is the special report that we're going to talk about, but we do all types. And how we deliver it to you and how we get the message out, everything has changed and hopefully improved. Not saying that it couldn't improve again, but basically we just want to make sure your monies are spent the way they are intended to be spent because it affects all of us. I know right now a lot of people don't think it's a big deal because we've gotten the first huge windfall of funds, the CARES Act funds, which not are all spent. And now we've gotten the American Rescue Plan Act funds, which is that second windfall of funds, which came directly to these town, cities, and counties and as well as agencies and school districts. So we have a lot of responsibility in this office, and we work very hard, and I have a fantastic team. So you can read about us at auditor.delaware.gov.
So does it have to be like what you do, your jurisdiction, does it have to be with the state operations, or does it involve with like the hospitals, for example, if they're not owned by the state?
It depends on who's accepting monies. For example, we have 88 long-term care facilities in the state of Delaware, and over 40 of them they've been on a rotating basis. So when I got into office, they were already under contract. They had put out a bid and a request for proposal, and they were rotating 6 a year. This was a schedule, what I inherited. So now this has changed this year. The contract's up. And what we did is we put out one and said, no, we want to do 12 or 15 a year. Why would you wait so many years to have to actually look at a long-term care facility? But these are the specific ones that we look at, deal with accountability data, and which directly affects maybe Medicaid, giving them money or grants, et cetera. So yes and no to what you're saying. If you're somehow touched with some of the things that overlap in which we do, anything with state monies, let's say a hospital took state money, well, that could be fair game then.
I see. All right. So now, what happened I think it was probably June, prior to June, when I was doing these events, we were trying to be creative, and first I had my doctors who were my guests, and I had my internal leadership. They were coming in, and some weeks I was kind of by myself and just going out there, and then I used these as my therapy session. So long week, and then I just come up and then talk, and it helps. So if you ever feel you need a therapy, you don't need to go anywhere. You can just do it, just go live and then just talk about stuff. But then we talked to Brian Townsend, Dave Vance, Valerie, and
Longhurst.
Yes, and then we have Sarah McBride and a couple others and then we reach out to some of the Republicans, and I'm independent, not on one side heavily. Republicans in Delaware, I think they're hopeless for whatever reason. They don't want to even answer. So because we want to be their voice too, so then we can answer, we can actually have a conversation. So we are open to everyone. Although I think your position, the guy who was before you, who did this for a long time, he was a Republican, right? Tom Wagner, right?
Correct.
And I don't know.
Yes,
when I say this, I'm being very naive. Maybe I don't know if you are a Democrat or Republican. It doesn't matter. You're independent. So, but like
it doesn't matter. I'm a
open.
Democrat, but it doesn't.
We're open. So, we're open for anyone, any voice. But what brought you to our radar was 24.5 million overcharges back from the state employees, and you did use the term PBB. And for those who may not know what PBB is, that's the pharmacy benefits manager. Mm-hmm. It's kind of like a middleman for the pharmacies. So now I'm going to bring this slide up, and if you can just give us a background on that. And I have some specific questions. As you know, I'm in charge of an accountable care organization. It's a value-based organization that we work with insurance companies. So as we do savings for Medicare, Medicaid, and commercial insurances, then we actually we make savings we get shared from those savings. So, and it got my attention from that point. And pharmacy is one of the big expense items for them. And it was extremely important for us. and wanted to know more about it. And I read a lot of what you did, and it was extremely impressive. And we were talking about this with other people, but not explaining it well. And now you're a pharmacist, although for your
Yes.
job, like that's not very common, I guess, right? So maybe like it was kind of also interesting. You started from, you have a good maybe start point with this. So if you can kind of give us a background, what really happened here, what the how this was actually, what the outcome of this was, and how we can actually fix this for long term. So I'm going to just share this and then have you explain this to us.
Okay.
Are you able to see the screen?
Not yet.
Our connection is probably a little bit going on and off. Not sure. Is it me or?
Okay, now I can see it.
Okay.
Yeah. Okay. It's very hard to explain, and I think that's the confusing part is actually not in our benefit. And we've had several different scenarios. And I have a couple examples that I wrote out, and I'd try and do it. But first, let me address one thing. I'm a Democrat, but my job is to represent everyone. And as I've told folks, my issues, they're not red issues, they're not blue issues, they're green issues, they're your money. It matters to everybody. And fraud just doesn't happen to people in certain political parties. I mean, that's why we represent everyone. We work for you, Delaware. We work for everyone. So I like the fact that you reach out to people across the board so you can have those conversations, because I think that more of that needs to happen. I go speak to anyone who will listen, to be quite honest with you. I don't care about party affiliation. I need to let them know what we do and what it means to them, because this office had been very quiet and we have a different style. With that being said, as you can read on the slide, this is all contract management. This is this is something where I believe that when we are negotiating big contracts or going back and forth and with the attorneys, bring in a subject matter expert, bring in somebody who understands and can read some of these things, because they're very tricky. And what we did is we showed that, the inflation rate in the national inflation rate between 2018 and 2020 was 4.7%. But for Delaware's employees, our prescription drug costs were like 20%. So, and the enrollment remained flat. So that's where we said, this is where this money is coming. This is the $24.5 million over 3 years. So, my auditors quadruple check, double check, everything, went through so many checkpoints to again, and again. That's why it came out so late. It should have come out months before. But we wanted to be sure. So the difference is what Delaware should have paid versus what it did pay. So that's kind of what we're getting at. That 24.5 million. I believe, Express Scripts could argue and say, well, we have the right to keep the money because of the vague contract. And that could be true. However, just because you could keep it doesn't mean you should keep it. And if you look across the other states, for example, Ohio, they just won $88.1 million back from a PBM, and they have more coming. So you have to fight for the tax money. It's your money. It's your money. And I know it's hard for people right now. And I have a lot of folks who just are like, yeah, but we're getting all this other money. We're getting infrastructure, CARES Act money's told to spend. We have the ARP funds. That's not the point. If we could bring in subject matter experts to not only one agency, but all the agencies, when you're negotiating huge contracts or maybe have a threshold where you're going to do so, I think it could really, a little bit of money in the front end could save us millions or hundreds of millions in the long run.
So Do you think many people don't understand their health benefits? Because this is actually coming out of the state employees' benefits, and state is a self-funded plan. And then
Well,
it says like, oh, this is my employer paying this for me. However, the issue that I see is, yes, your employer is paying it, but as this is getting more and more expensive, 2, 3, 4, 5 years later, that cost is getting so heavy. At some point, either we lose some of the benefits, or we lose the quality of those benefits, or we start paying for some of those benefits. And I spend a lot of time on that, educating my own employees. And our HR actually spend a lot of time, and we want to be competitive with other employers to provide best benefits available out there, but it becomes so expensive. So, and state spends so much on healthcare. Cost of the state budget, like 1/3 of the state budget is between the, well, this is one third is for the DHSS, if I'm not mistaken. So it's so big, and everyone should be more aware of this. And this is from like one line item that you are saving 24 million.
It's scratching the surface.
Right? Yeah. And you know, the other thing is we part of what we do with this digital age, with the pandemic, we started meeting with our providers on through Zoom meetings just like this. Started with every day in the beginning. Now we keep our Monday and Thursday nights, and we give them updates and some of the other business issues we discuss. And one of the issues came up last night was the pricing, hospital price transparency. So one of my directors, Anthony Onubu, he was actually presenting this, and Tanner, who was in touch with your office, and he's not here today with me. So I just immediately said to him, well, we have to bring this up tomorrow with Kathy. So, and actually I had that item with me, and this is another problem, and I don't know if this is something that you would like to discuss today or maybe some other time. I do want to kind of bring the screen up, and this was on the this was in the news. Now there's also this problem of hospitals not being compliant with the price transparency, and unfortunately, I think our state hospitals are on the non-compliance list too. And they do get Medicaid money, and they do treat state employees. So this is the Medicare rule. So by 2022, everyone should be on this list on the compliance side. And Delaware hospitals failed to follow federal price transparency regulation based on this report. And this was on July 23rd on the Delaware News Journal. So when I see this, it's kind of like sad in a way that even like our biggest organizations, biggest employer at the same time, like someone like Christiana Hospital, BB, Nanico, AI DuPont, St. Francis, they're all failing this. And now I do own a surgery center. I'm one of the partners of a surgery center, and from the pricing standpoint, we are very much aware of the differences between what's being paid in the outpatient setting for Medicare is paying X for, let's say, colonoscopy. Then same colonoscopy. I'm going to give you an example of gallbladder because I'm 100% for the number. In the outpatient setting, cost of gallbladder is $2,000 for Medicare member. Average is $12,000 in the hospital setting. Now, there may be differences based on how they are billing it. Just from the fee schedule itself, this is costing our elderlies a lot more. So $2,000 to $12,000. And we understand in some cases there are emergencies, how the patient comes to the hospital and how many days do they have to stay. But some of these can be handled by preventive medicine, and if we can actually schedule them ahead of time and all that. But when you see this type of a gap, like from 2,000 to 12,000, and one of the insurances gives us a star rating of the pricing. So if the hospital, actually it's not a star, it's a dollar sign. So X place is $1 versus the other place is $5. So that's a big difference. So for the same service. So is that something that you are also, that would be in your jurisdiction as well?
It could be. It all depends. I have to tell you, getting back to this confusion of what you and I are talking about, we have to get it to the point where we can communicate with the public where they understand it, because they certainly understand when they sign up for a plan and pay for it and walk into the pharmacy and now that drug isn't covered anymore. Mm-hmm. Or they certainly understand when they go to have a procedure and now they have to pay more than they thought originally. So those kitchen table issues, the public understands. But when we speak in generalities and the big things and the pharmacy benefit manager, and they're the middleman here in this, we lose people. And that's what we try and do is speak in everyday terms, because sometimes this stuff is way too technical for the person, the average person who's busy, worried about what am I going to make for dinner? I got to get the kids to soccer. I'm working, I'm stressed out, or whatever their life is. So at the end of the day, they do understand what affects their pocketbook. And I will say there's different levels of noncompliance as well. You certainly have to hit certain boxes depending on or check certain boxes depending on what type of engagement it is. And then you come into different types of findings and there's different levels. But when you are either a hospital or a long-term care facility or what have you, and those, you are not compliant, there has to be some kind of accountability. You should be given a chance to make it right. What we have found recently, or at least I have, I'm only in my third year, but I'm seeing people that are repeat offenders year after year. And I'm like, well, why are they still getting that money when they're told they have to follow? The other folks are playing by the rules and they're getting X amount of dollars. And then this person is not. When I first came into office, I had a lot of questions. I still do, but I had a lot more in the very beginning. And I said, what happens to someone or an entity when they have findings and recommendations? What happens? And I heard nothing. And I went, so why are we even giving homework and checking it if no one's going to do anything about it? There's no way for us to improve if we don't know where we are right now, period. There's no way to improve. Just like you have a coach, they tell you, oh, you're doing this wrong or run that way. That's how we get better. So what I did immediately is I sent a survey to all the other states in the country and said, do you have a program? Do you have something? Can you share your materials? And I had several states get back to me, very kindly giving me their information. And we took the whole program, we laid things out and created one for Delaware. So now when you have findings or recommendations, you will be put into a different program now. It's called the follow-up program. Very creative name. And we have several people in that lane. We give them 6 months to address, resolve, or fix, because at the end of the day, if they can do a process better, if they can hold something accountable, if they can serve, the state better or a client better, it saves money. It can save lives too.
Yeah,
so all of these things are intertwined, and it all comes down to
the
dollars.
Cost is like in healthcare. We provide this, and we again, I do have ownership in some of these primary care and the surgery center. Primary care, we compete with the hospital-owned primary care practices. They get paid more. So by all insurances, including Medicare. So, but then I have to hire same physicians, same level physicians. They are, graduating from the same medical school, same residency. We have to pay same salaries, same benefits in order to stay competitive. And we actually have to compete, and we have to provide even better service and survive. So last night, I just want to give you because it just happened last night. So I got home. It was a long day. Our provider meeting stopped. I'm finished at 7. There was another follow-up, and I called this patient around like close to 9. You can check my phone records. Since you are the state auditor, maybe you want to audit that. I have it right here. So I was on the phone with the patient for 40 minutes. Issue was patient refuses to be vaccinated, and patient has issues. And patient is my mom's age. And I'm 47, and like, how can I actually help this person to get on board? And even if they don't want to be, there's a disconnect with the office and the patient, and patient's upset, office is upset. And I'm the CEO of this practice, and I don't see patients, and I don't actually go to that office. And I never met this person in my life, but I want to help them. If I'm the hospital CEO, I'm just going to be at my home and just done by 5 p.m. and then get paid already okay. But then no, I have an unhappy patient and I have an unhappy provider, and then we have to figure out how we can actually help the patient. Patient has some outstanding labs, and my main concern is, I said, look, I don't care if you don't want to get vaccinated, but we have to take care of you. Like, that's the main thing. At that point, we don't care how much we are being paid. We are just looking at, okay, we have liability issues, obviously, but we have quality issues. We just from being, like, I see that patient like a family member at that point, because the values are not good. So just taking a risk of, maybe they will find someone else, that's not an option. So you can go back and then just live your life as nothing happened, because knowing that something can happen to that patient. And in the meantime, what you don't want to feel like you are being treated differently from the system. And I think that's why we appreciate your position and your findings and you addressing these types of issues and understanding and supporting us. Because for a long time, I felt like we were alone and like no one is actually looking after our rights, because we don't want to necessarily get paid more. We don't want some other people, other entities being paid more for the same work that we are doing. And we don't want people to take advantage of our patients, our employees, our state dollars. So, and for that, we do appreciate for the work that you are doing. And is there anything we can do from our side to help your work in terms of HR and the things that we can do with our contracting that we can share from the real data that may help you to see some of the challenges that we are having? I just want to ask you that because we do have a leadership team that understands what's happening very well. So they may give you some real life experience or examples and data if you would like. I just want to make sure that we offer that.
Absolutely. It's interesting hearing you talk, because the smaller, the independent, the small businesses are the ones that are getting squeezed. Actually, it's not getting paid for the same level of service. You're getting paid less for better service a lot of times because you have more of a relationship with that patient. As I said with the pharmacist, that's your first line of defense. When you have a sore throat or athlete's foot, you go into the pharmacy. You want to talk to someone. And usually, and I know I owned an independent pharmacy, your customers do become your family. You're absolutely right. You care about them. You want them to heal or get better. You do those extra things. You get up at 2 a.m. when they get home from the hospital and they need a prescription, and you're in your pajamas in the store. But it sounds very much like the pharmacy benefit manager, the middleman, because the independents are getting paid less. Now the pharmacy benefit managers, it's kind of like the DoorDash or the meal delivery service that owns the grocery store and then tells you what kind of carrot you can buy and then tells you how much they're going to pay you. And it's ridiculous. But I will tell you, they have very sharp attorneys and a lot of money. And so as I think we realize and recognize and reveal and shine a spotlight on some things, there's something already in the works. I'm not stupid. Neither are you. So we know that's happening. And, they're business people. Of course, they're going to look at their model to make a profit. But I do feel that we need some tight legislation, which is waiting to be signed by the governor, that was voted on unanimously. Not only that, in Delaware, because other states are starting to do it, I think we need national at this point. We need national legislation. There's still a way to make money, but not rip off the small independent and squeeze out, the ones that are your first line of defense, the ones that are there for you, that you can actually have access to. As you said, somebody talked to you for 40 minutes. Well, they were able to talk to you for 40 minutes. That's unreal. So, there's about 40. We did a survey. There's about 44 independent pharmacies in the state of Delaware, and we took a sample and surveyed them. And I'm really excited because I'm not sure if, as we talk, that report's coming out right now, today. And that talks about the predatory prices. And it speaks a little bit more to, what the pharmacists said. Now, obviously, we're not going to say who the pharmacists are in their stores, never, but you're going to get to see real live quotes in this as well, and some data. We always need data. Thank you for offering. If we can have data, we have some folks who are really getting sharp with the analytics in the office, and that's everything. You cannot even make a decision without data, and data matters. But let's take that a next step and talk about the auditor's office. If I don't have access to that data, it's a problem.
It is.
Isn't it?
From the Medicare shared savings, 2020 numbers just came out yesterday. Per patient for the same plan year, for the same program, there are different programs, and then for this apple-to-apple comparison, so we are the most shared saving per patient for 2020, while we are competing with all the other programs. So that makes us the least expensive Medicare ACO in the state of Delaware. And we are a private group. I do this by myself. When I say by myself, of course, my admin team is here, but I don't have any hospital supporting me. I don't have any other entities supporting me. I have my leadership team. I have a couple of directors with me, my independent physicians. That's all we have. Not medical society, not Catholic organization. I mean, St. Francis Hospital, no Christiana Hospital, nothing. We do this on our own, and we are the least expensive Medicare organization in the state of Delaware, and we are proud of that. And we are surviving this for the years and years and years. And this is doable. You don't necessarily need more money. We just need right directions and right people on the bus. So if people can actually promote that better, and sometimes we go to these healthcare facilities, and you go into this humongous lobby and all the granite and all that. You don't need those to get better. You need, like right now, we do that on a video call, and you can still treat the patient what they need. So, what you go in and you see this, overwhelming lobby, and who needs that to get better? You just need to get better quality health. You know what I'm talking about. So
I know exactly. I hear you. And sometimes it's a curse when you care so much.
Right. So we do, because we want to go home when we are sick. The best place for us is home, not like, luxury in the hospital. Home is the best place for us to get better. So, and we don't need to make expensive places, so that you don't have to audit them and we don't have to pay for it. So, and I'm hoping that we can, if we can work together on whatever you need from us, that my office can provide. Our team is in the last 6 years on the accountable care organization. I think we mature now that we have so much data. We do so much with our data, and we can help you for whatever can be given to you in the legal limits, obviously. But this was a lot of information, good information, better understanding. Hopefully we help for some people to understand this better. And thank you for joining us. And I don't know if you have any closing comments, but this was.
Well, yeah, I do. I do. The PBM with the 24.5 million, earlier we put out a report when we looked at the Department of Corrections prescriptions, and we showed they could have saved over 44 million in the past 7 years. We've showed over 110 million dollars in potential savings or overspend or in the first 6 months of this first 6 months of this year. We showed that. So, I need people to care about how their money's spent, just like the ARP funds. It's great you're getting $10 million, Mr. City or Mrs. Town, but how are you spending it? And people want to know, how are you spending it and how does it benefit them in their community? That's what they want to know. At the end of the day, are you going to fix my pothole? Are you going to do that bridge? Am I going to get broadband? Whatever their needs are, whatever's on the laundry list. But, this office is so important. It is so crucial. You're right. We have a lot of money. It's how it's spent. It's how we do. And it is not a gotcha office. Yes, we want to reveal things, but that's my job. Just like I had my own office audited by an outside firm. I opened up everything and said, show me where I am and tell me where I need to go to be the best in the country. I had a lot of work to do, but we're getting there. We're getting there. So I need your listeners. I'm pleading with them, and they can get them online. They can go to the state of Delaware website, email your senator and representative, email everyone that that is elected and say, look at the auditor's office. We care what they're doing, and we want them to be able to have access, because not everyone cooperates, and that's hurting you.
And I can tell you, maybe I'm glad to hear all those, because this is 2021, almost 2022. And one of the best part is what we are doing right now. So last year, summertime, we started doing it. First Zoom, YouTube going live was not a good experience. And Dr. Erkan, one of my best friends and my business partner, we were kind of like nervous and trying to make it work. And now it's so seamless. So then I didn't have to do a lot of prep and technical stuff, because we have a couple of people helping us. So it doesn't cost us anything. And then you are in your office, I'm in my office, and then we are talking. My dad is in Turkey and he's watching this. And because he's asking me, who's this pretty lady? He's 80.
Hello.
So now imagine how powerful this is and how easily we access to people's home, and they can hear this. And the video we did with Sarah McBride, it reached out to 25,000 people. So we have 115,000 Delaware primary care patients at the primary care level. So even if 10,000 people hear this, and from the different channels they hear it, so that's taking this message and getting it to them, and hopefully they understand. That's and this is the main reason that we are doing it for our patients too, so that they actually understand why we care. Because we share so many other things. On Wednesday nights, we do diabetes accreditation. Like we have the diabetes accreditation, we do diabetes sessions, Wednesday wellness sessions. So at 1:30 on Fridays, we have bariatric Friday, we call them. We do events for our patients with morbid obesity, so weight loss surgery. So we do another event. So I think we need to take advantage of the technology and give our messages to those people through these channels. And I think we are in the right place, right time. So, and we want to make sure that we can be your voice as well. And I'm so glad that you were able to join us. So, and hopefully,
thank you for having.
Hopefully, we'll have a follow-up for this, so that there's a couple follow-up items that I want to discuss those with you. Maybe we can just meet again, and then after that we can have another YouTube session to have a follow-up.
Absolutely. I appreciate it. I appreciate you caring. Obviously you do. And thank you for having me on. It's been an honor. And thank you for caring how your money's spent and sharing this.
Absolutely. All right. Well, thank you so much again. Bye-bye.
Take care.